And so if you're looking at the groin at this point, hopefully in just the amount of time that I've talked to you, I would have done both of these sticks. And I have an antegrade stick going into the SFA and micropuncture wire hanging out. And I have my retrograde wire sticking out also.
Hello, cardio nurse CathMasters. Welcome to the Proctor's Playbook for VA-ECMO. This is Nazlı Okumuş, and we are back with Doctors Daniel Embender and Gage and Marwan Jumian. In the last episode, we discussed data to delivery for using VA-ECMO. In this episode, we will open up the Proctor's Playbook as Anne and Marwan walk us through an actual cannulation. As a reminder, Dr. Gage is trained in interventional cardiology and critical care cardiology, and Dr. Marwan Jumian is trained in interventional cardiology and advanced heart failure. Our patient is a 36-year-old man with acute fulminant myocarditis with biventricular failure, pulmonary edema, and cardiogenic shock. He couldn't be in better hands today. Anne and Marwan, thank you for joining us in the Cardio Nurse Cath Lab.
Thank you so much, Nazlı, for inviting us back, and I'm excited for this conversation. I'm planning on learning from Marwan how he does this so expertly.
Looking forward to seeing what you do as well. Thank you for inviting me.
Okay, team, close your eyes and let's set the stage. We're in the cath lab control room. The lights are dimmed. The patient's on his way. We are lighted up and ready. And what do we need to know about the patient to get ready and prepare? And as a related question, how do we select cannula size and configuration? What tools do we need to have in our toolkit? And how do we think about getting them and obtaining them?
All right, Dan, I want you to get out of your lead for a minute because it's heavy and hopefully we have a lot of years ahead of us with our backs and our bodies. Because I think that how we set ourselves up for success probably begins with our procedural planning. And one recommendation, I guess, is that we don't do this in lead if we can avoid it. But, cannulation for VA-ECMO is a team sport, and it requires significant pre-planning and coordination of care to take care of this very sick patient. And hopefully we have a little time to do that, maybe only a few minutes. But at least we begin by reviewing the patient's history and all of the primary data. This informs our support strategy and allows us to determine what equipment we need. And actually, we can script how we expect our procedure to go. So we want to make sure that we review the patient's pertinent history, including prior imaging of the groin and leg vessels by angiography or prior CTs if available. And I think that reviewing all this primary data with the team is imperative. This includes looking at his echo, his invasive hemodynamics, angiography, CT scans, EKG, and labs. The invasive hemodynamics allows us to phenotype the patient as left, right, or bi-V shock. Phenotyping the shock allows us to choose the right support configuration. Echo will additionally allow us to assess the biventricular function and confirm any valvular disease. And in many cases, it may also help us refine our differential diagnosis for etiology, which would then play into our next treatment strategies. So for example, wall motion suggests CAD, or severe MR secondary to a flail mitral leaflet may suggest a delayed complication of a myocardial infarction. Obviously, we should also be reviewing the EKG and the labs. All of this data helps ensure we have the correct diagnosis, we've delineated our shock phenotype, and allows us to choose the cannulation strategy that is most appropriate for this patient, and then we pick our equipment. So this patient is very unlikely to have any contraindications to ECMO based on what we know, but ideally the team would then run through your program's list of relative or absolute contraindications to VA cannulation. In my hospital, we actually have an ECMO timeout that now that we're all leaded up, that we are going to perform immediately before we cannulate. And as part of this, we list all of our contraindications to cannulation and ensure the patient is appropriate for the procedure. So as for the actual equipment, you will have to select the sizes of your venous and arterial cannula. Flow through the ECMO circuit is determined by the size of your venous drainage cannula. I usually attempt to place a 25 French multi-stage venous cannula for most patients, although it is possible to use a 21 or 23 French. For femoral VA ECMO, the arterial cannula is usually a 16 to 20 French single-stage cannula. This is based on the patient in front of us and their vessel size. We may know this from prior angiography, from review of CT scans, or actually just looking at the patient and their size, their BSA. There's definitely a trend toward using smaller arterial cannulas when possible in order to minimize bleeding and ischemic complications and to potentially facilitate percutaneous removal. So some programs are routinely using 16 French cannulas as their upfront strategy. We typically are a program that will use 20 French cannulas.
Most of the ECMO cannulations for me are done outside the cath lab. So they're done in the ICU or in the emergency room. Rarely we have the luxury of time to get the patient to the cath lab. So we get the ECMO cannulation equipment onto a cart, and whenever we have to, we just move the cart to the patient's room. The cart has, in addition to the vascular access kit, cannulas, as Anne mentioned, we have dilators. We have the guide wire that I use. I usually use an Amplas super stiff wire. I always dilate before I put the cannula in place. And we always have a surgical cut down kit just in case there are some issues with access. And usually it's the cannulator, which is typically an interventional cardiologist or cardiac surgeon. We have the ECMO perfusionist, an intensive care nurse, or a cath lab nurse. And we always have access in the cath lab or OR just in case something happens. But I agree with everything else that Anne said regarding cannulation and cannula size as well.
That's a really helpful framework for getting prepared. In the cath lab, things happen fast and things can go south anytime in a heartbeat. And to be able to react on time and with the best approach, it's really important to be prepared, not just for the operator, but the whole team. So thank you for mentioning the team role as well. From understanding the patient to choosing the right cannula, you covered everything. Marwan, who should be in the room and what equipment do we need on hand?
Typically, the cannulator, an assistant, whether it's a fellow or if the surgeon is cannulating, typically two people scrub in to cannulate the patient. We always have a perfusionist so that they can hand the cannulas and the equipment for us and start the circuit. And we also have an intensive care nurse. With respect to the equipment, again, as I said, we have to have vascular access kit. I usually start with a micropuncture and use a dilator over an Amplas super stiff wire. For the venous cannula, I use a 23, 25-inch cannula multi-stage. And for the arterial cannula, I use a 17-inch, unless based on the body size and peripheral vascular disease, I may alter that. Having an ultrasound for guidance is really good, but in case of an emergency, we may not have the luxury to do so. And then with respect to who's in the room, as I mentioned, we have, in addition to that, the surgeon is always aware of what's happening. The ECMO team is always aware of what's happening in case we need to talk about what the next step is for the patient.
Thank you both for going over those details. So this is not as a sexy debate as LV unloading, but Anne and Marwan, what is your approach or whether or not to use a distal perfusion catheter? And also, we did allude to this earlier, but what is your approach to adding an unloading device up front, like right now? Anne, why don't you take it first?
Okay, so a distal perfusion catheter should be a standard of care, and I always place one. I think pretty straightforward there. As for the unloading device, I think we discussed this in our last episode, and so if you didn't get a chance to hear that, I think this is a very in-depth topic. We kind of touched on that. I frequently place one. However, as I mentioned, I don't think that this is always necessary. I think that it's based on an assessment of the underlying etiology of the patient's shock, the expected time frame for potential recovery. And then we're looking for things like aortic pulsatility. Is there a pulse pressure of, normally most people will reference 20 millimeters of mercury, and the presence of aortic valve opening on ECMO. If we have some pulsatility and the aortic valve is opening, I don't think that it is always necessary. But I'll say that just probably out of convenience and the fact that our experience has been that most people are not as pulsatile as we would like, don't meet that 20 millimeters of mercury initially when cannulated, that we frequently are going upfront to an unloading device.
I agree with that. And an antegrade perfusion sheath is placed routinely in all patients. And if you're cannulating in the cath lab, most likely the patient will get an unloading device until we figure out what the next step is.
Thank you both for sharing your approach to distal perfusion and unloading. It's great to hear how you think through that upfront. And now let's talk about anticoagulation. The patient weighs 70 kg. How much heparin do you ask for and when does it get administered?
Oh, good question. So our protocol is to administer 70 units of heparin per kg, and it's given after vascular access, but before dilation. So for this person, 70 times 70, 4,900, I would ask for 5,000 of heparin.
Perfect. Okay, so let's get the show on the road. Marwan, can you please walk us through the step-by-step cannulation strategy, beginning with access? And I know you did talk about micropuncture, but just so that we all have it together, how do we do this?
Ideally, you have to be really, really good at access because most complications that can happen immediately are related to access, especially in ECPR when there's chaos in the room. So using ultrasound guidance, if you can, placing an arterial and venous access using a micropuncture needle, getting access with a micropuncture dilator sheath. And then after that, I usually use an Amplatz SuperSif wire and I dilate carefully. I usually upsize. So let's say I'm putting a 25-inch venous cannula. I dilate the track with a 27 so that it's easy to get the 25 in without having any issues. The enemy for cannulation, especially at the bedside, as you dilate, is if you kink the wire, then that's going to be a problem. So the key is to make sure that when you remove the dilator, I always move the wire in and out just briefly, just to make sure that everything is smooth, nothing is stuck. Once I put the arterial cannula and the venous cannula in place, I clamp them. The patient's heparinized, and then I use a wet-to-wet connection and connect the arterial and venous cannulas and start the circuit. If I have the luxury of time, I'd like to put the antegrade sheath before I put the arterial and venous cannulas in, just so that the real estate at that area is covered. So I use that under ultrasound guidance, sometimes under fluoroscopy, where I can access and visualize the wire going down the SFA so I can place a 6 or a 7 error sheath there. And then I use that to connect it to the arterial limb of the circuit.
Okay, the patient cannulas are in and flow is established. Something I love about interventional cardiology is learning from different operators' unique styles. And is there anything you do differently in your cannulation strategy?
So I've done one thing that is slightly different, and how I've taught fellows to do this also is that I think that the antegrade reperfusion sheath, the stick for that, can actually be very complicated. I find it to be one of the more complicated sticks that we do. It's high risk and there's a lot riding on it. We're going to cause ischemia to this leg, and then we're going to systemically anticoagulate them. So we have just a lot of risk for ischemia to the leg. So with the exception of ECPR, I think that is not the situation I'm talking about. But I find it much easier to do the distal perfusion catheter stick at the same time as my retrograde stick. So what I mean by this, if I walk you through what I do with my hands, is that I hold the vascular ultrasound probe with my left hand, and I stick the common femoral artery in a retrograde fashion using my right hand with the micropuncture needle. I then wire the micropuncture needle with the micropuncture wire, remove the needle, and then I just leave the wire there, not going anywhere. It's there. And then I quickly swap my hands. So I'm holding the probe with my right hand. I scan down just a little bit towards the feet until I find the SFA and a good target for my antegrade sheath. And then I quickly, using my left hand, do an antegrade stick with this left hand and the micropuncture needle. And I again place the micropuncture wire through the needle, remove the needle. And so if you're looking at the groin at this point, hopefully in just the amount of time that I've talked to you, I would have done both of these sticks. And I have an antegrade stick going into the SFA and micropuncture wire hanging out. And I have my retrograde wire sticking out also. So then I usually, if I have a reasonable view, I've done this in less than 30 seconds. I then pick one wire to work on first. I place the 4-French micropuncture sheath, remove the micropuncture wire with an 035 wire, and place a 6-French pentacle sheath on each wire. So each stick, and I end up with 2 6-French pentacle sheaths. And then hopefully I've done excellent access at that point, and I can begin to upside, to dilate and cannulate. And I think that this allows for the best view that I can get without a cannula in the way to maneuver around, and I get the best image that I can. So it's much easier to do this before you've decreased your flow down the SFA after the placement of a big arterial cannula. So this is my routine. So long as the patient's actively undergoing CPR, I do not put the reperfusion sheath in at the same time. But I really think that if you do this and you do it kind of in this way, that normally I can have all of that done in less than 30 seconds. And I'm willing to take that in order to get a good stick.
And that was a super useful tip. And I've definitely seen it performed the other way, where you have your cannula in and it becomes just so challenging afterwards. I am positive that our listeners are going to appreciate that tip and trick. So Anna Marwan, what is the vascular closure strategy during decannulation? Is it typically performed surgically or percutaneously at either of your institutions? Let's start with you, Anne.
Yeah, so I actually think that we're in evolution with this. And as we progress and everyone's skill sets are improving, our first line strategy is a surgical cut down. And we've kind of oscillated between that being with our cardiothoracic surgeons or our vascular surgeons. But just given scheduling constraints and resource availability with the cath lab and ORs, we have gone to a pathway where we can do percutaneous decannulation. And so for patients who are being cannulated within our hospital, where it's one of our program is one that interventional cardiology will cannulate for ECMO in the cath lab, if time allows, that is our standard. And in that situation, if it's an interventional cardiologist who did the access, we expect that there will be imaging of the access so we know what the vessel looks like and whether or not we were successful with a good stick. And then in that situation, so we do angiography, and then we will pre-close our ECMO cannula sites. And then if we did it, we know the vessel anatomy, we know the stick, and we pre-closed, then we will percutaneously decannulate. If we didn't have time to pre-close, then we can still percutaneously do this. We would cross-clamp both cannulas and then use a 16 or 18 gauge needle to stick the plastic part of the cannula, wire this. So put the large bore needle in. You're going to get shot with a little bit of blood. Even after you've cross-clamped, then we would wire with the Amplat super stiff wire and come out with the cannula. Depending on the situation, we would potentially use like a 2 8-French technique where we put 1 8-French cannula over the wire. We then would put in a second wire, so 2 wires through the 8-French cannula, remove the first 8-French sheath, and then rewire each wire with an 8-French cannula and per-close both of those. Sometimes, depending on how good of a pressure holder I have from a cath lab tech, we would actually just come out with the catheter or the cannula over the Amplat super stiff wire and then deploy 2 pre-closes. If we do that, we always, before we remove the wire for the second pre-close, we take a 4 French micropuncture sheath and image just to make sure that it doesn't look like we've occluded the blood vessel. And I would say that if you're doing percutaneous decannulation, knowing that what your pulses are in your foot on the side you're decannulating before you start is really imperative. So you know what you're comparing to after you've successfully percutaneously decannulated.
And Marwan?
Yeah. So with the evolution of temporary support devices, a lot of patients are sent to the operating room for a VA-ECMO decannulation, and they proceed to get an Impella 5.5. So the patients in the operating room, the surgeons will decannulate and then cannulate for LV only with an Impella 5.5. So we have not done a lot of cath lab ECMO decannulation unless it's planned, such as for high-risk PCI as a temporary thing during an AMI. Then they are pre-closed, and then we'll do post-closure, with per-closed devices, but that's about it.
Yeah, I think it's actually a really interesting point. I think that this is totally program dependent and that it's depending on what your resources are. I think you're exactly right, Marwan, that a lot of times these people are going anyways to the lab. And truly, when you see what the surgeons can Fogarty out of these common femoral arteries, there's usually a good amount of thrombus there. So we are building our experience with percutaneous. I shut down the leg. So at that point, you're like, well, do you call it or not? Do we ever do this again? But we've sort of advanced in kind of being more selective. If we do a percutaneous decannulation, we always have a surgeon who is aware and available. And then obviously, if you have the skill set as an interventionalist to get at contralateral access and come up and over and sometimes bail yourself out, that is a good skill set to have. I will say that our surgeons are frequently, some of them per-close on their own, but frequently one of the interventional cardiologists will pop in, even if they're going for a 5.5 or they're being surgically decannulated, just to per-close the antegrade reperfusion sheath, just to make that one less thing that they have to deal with and potentially a smaller incision.
Thank you both for sharing your unique experiences and your approaches. It's always really helpful to hear from different operators and how things go in different institutions. And then Marwan, thank you for this amazing collaboration on such a fun and insightful episode. I truly enjoyed diving into the nuances of VA-ECMO cannulation and hearing your unique strategies, from mechanical unloading to anticoagulation, vascular closure, and everything in between. Cardio nurse CathMasters, thanks for joining us. Stay tuned for our next episode of Crisis Control, where we tackle complications head on, because the real mastery begins when things get tough. See you there.